All right. Welcome to this edition of Let's Talk, presented by the Visiting Nurse and Hospice for Vermont and New Hampshire. I'm your host, Anthony Knox, and I thank you all for joining us, whether it's live or if you're watching this recorded later on. Just a quick reminder, please, take a moment to follow us here on YouTube for the latest Let's Talk videos, as well as following us on Instagram and Facebook. And if there's any information that you're looking for related to VNH, don't hesitate to go to our website, vnhcare.org. On this edition of Let's Talk, we are going to be talking about occupational therapy, what it is, and how it's helpful for you as a patient. And today, actually, I've got two guests versus the traditional one that I normally have. I have Nadine Nelson and Lily Finnegan-Allen. So I'm going to let them introduce themselves. So Nadine, we'll start with you.
Good morning, everybody from rainy Vermont. I'm Nadine Nelson. I'm the clinical manager for VNH for the Southern region for home health. I started with the agency about 8 months ago, and it has been a wonderful experience in a very supportive environment with leadership, which I can then pass along to my crew. So I'm very fortunate to have that. I actually moved from South Africa in 1994, so I'm a bit of a transplant to the area, and it was a bit of a culture shock. I think the biggest thing that really stands out to me is being a part of home health has really allowed me, after 27 years, to be able to contact people and be around them in their home environments. So that's been a learning experience for me, and I wish I'd actually come across this a lot earlier in my career. I actually started in the restaurant business and then did restaurant management, ended up having my first daughter, and at that point was like, home birth seems to be something that sort of popped in my head for whatever reason, which is what really started my trajectory in healthcare. So my first career was restaurant management and then led into healthcare, and went to nursing school, was an LNA, LPN, associate degree nurse, bachelor nurse, and now working in my master's degree. But it was always back to that holistic approach for nursing. And I was really fortunate to be at Dartmouth-Hitchcock for 7 years, where I worked in hematology oncology, was a supervisor there, and then that led me into another leadership role in the hospital as a house supervisor for the Dartmouth-Hitchcock inpatient side, which was a wild experience during COVID and an incredible opportunity to look at the scope of the region from a very different perspective. I was tapped on the shoulder about a little over a year ago, from Erica Bergeron at VNH, who was like, you should really think about coming over to VNH. So 6-7 months later, I took her upon that opportunity, and it has been an incredible experience. And home health is it's wonderful. It's a great place for people to be able to heal at home. I myself have had 2 home births, so that I've always had that embedded in me, that being at home is a very therapeutic experience even for that. So to be able to come back to my roots of what I really wanted to do in a home health setting with an interdisciplinary team, physical therapy, occupational therapy, and the nursing crew is just a wonderful experience. And Lily actually started the same day I did at VNH, so we've gone through this journey in the past 8 months together, and she just brings so much experience, expertise, so much compassion for her patients, is a huge advocate, and I'm so happy to have her on my team for sure. And she's going to actually share a little bit more about herself and what occupational is for the agency, and I'm going to hand it over to Lily.
Oh, Nadine, that was so nice of you. Thank you so much for having me. I'm just flattered, and thank you, Erica, for thinking of me as the occupational therapist presenting this. So I'm going to go into my background. I'm kind of like you, Nadine. I didn't start off thinking I was going to be an occupational therapist. I started my journey early with wanting to help others. When I was really young, I was about 7 or 8 years old, I wanted to help my grandmother just make a sandwich for her. So I spent most of my time when I was like, say, maybe in grammar school, middle school, and also high school, caring for my grandmothers as they aged, and they both ended up having dementia. So I spent a lot of time in skilled nursing, the memory care unit, and I would take my grandmothers out to get some ice cream, or if I felt like they needed nail care or getting into the bathtub or whatever, like I just wanted to help them. It was like a natural inclination to want to help. And this is, by the way, like nothing I thought I would ever do, like become an occupational therapist and help people so intensely. I was always like into the arts. So I was into theater, but then I was also into painting and oil painting. And naturally, that's what I kind of went into. So I got my bachelor's of fine arts in, sorry, someone's calling here, in the painting, and I was able to travel throughout Europe on an art scholarship and live in Italy and travel Italy and travel and live in England. So I had a lot of experience kind of exploring my area and also doing a lot of art. Now, I then graduated. And graduating with an art degree, especially in painting, is not a very lucrative thing. So I tried to kind of in my 20s become an independent contractor, do art. I sold art. I worked in an art gallery in Martha's Vineyard. And I also did more traveling where I went and backpacked in Patagonia. And I also worked on an organic farm in Uruguay. So I digress. I was very exploratory. I loved doing things. But then I was like, how am I going to make money doing this? And so I kind of had to step back and figure it out. So I moved home and I started working at a school district, substitute teaching and doing an after-school program. And at that time, I was introduced to occupational therapy. And because I shared an office with the occupational therapist, so I was able that year to just kind of observe her in her like own natural environment and see what she was doing. And she was creating all these treatment plans to help, the children get stronger grip strength and their fine motor control, increasing the strength in their hands. And they loved doing it. Like she made it fun. And I'm like, this is what I want to do. This is an amazing profession. Little did I know that like, even though it was just within the school setting, there's so much more to occupational therapy because we're like everywhere. But I feel that creativity and occupational therapy go hand in hand because you really have to think up on the spot. And even with my art background, I find, so I was a landscape painter, so I would do plein air painting, which is kind of like you just go to a site and like kind of like Monet, sorry, I'm saying kind of, like Monet, just going to the landscape and observing that landscape at that specific time. Well, I kind of feel that my job is similar to that. I am going to someone's home, their own environment, seeing and observing what they're doing, and then also just making and formulating this treatment approach or plan that is geared towards that specific person. So every time I go into a person's home, it's like a blank canvas, and I just start kind of doing that, and it's just natural. So that's why I kind of came to OT. So I ended up having to go and get my entry-level master's degree, and the rest is history.
Awesome. Thank you both for sharing your stories, and I think it's time to dive into the presentation and really talk about what occupational therapy is. So, Lily, I'm gonna let you take it away.
Okay, so I want to start out trying to differentiate occupational therapy. People always ask me, well, what's the difference between occupational therapy and physical therapy? Well, I would say that physical therapy works with mobility tasks, getting to and from a surface, and more of the physical, like strengthening and range of motion. We do that as well, but we're more holistic. And we also address self-care tasks, everyday living. We are not people who get occupations for other people. We work on people's everyday occupations to make them more independent. So that's the difference between OT and PT, because that's always a question that people ask me. So I'm going to move to the next slide so a lot of times people get us confused with home health aides. We do help with self-care tasks such as dressing, bathing, toileting, grooming, blah, 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 hygiene. Well, we are also, very educated in science, on a science background. We've had anatomy and physiology. Like, I would say, I don't know how many classes I've taken with anatomy and physiology. We have to know every chronic condition. We need to know cognitive impairments, how to deal with cognitive impairments. We need to learn about vision, how we treat vision. There's just so much to occupational therapy that people don't understand that is layered. The profession is layered. We are an allied health profession. Now, allied health professionals, I was talking about physical therapy, that they are one. There's speech and language pathologists, which focus on, swallowing and cognitive retraining. And then, there's the athletic trainer. I'm not sure if skilled nursing is a part of allied health, but I'm assuming it is. So that's what we are. We're also evidence-based. So evidence-based means we research what has worked in therapy online on like these databases where you see a population of individuals and how they responded to a specific treatment. Say it's like a total reverse shoulder and how certain exercises helped with their range of motion post-surgery. So we also are very evidence-based. We're science-driven. Like I told you, there's a lot of science behind what we do because we're treating people that are sometimes critically ill, and have a lot of physical ailments that may need to be addressed within their plan of care. Because say someone has a non-weight bearing status, which means they cannot put any weight on their arm, how are they going to dress? There's the problem right there. So it's science driven. And then, like I said before in my background, we're patient-centered. So we are individually making and gearing the treatments towards the individual and what they find meaningful and purposeful. So, okay, that's what it is. So the role, so in a nutshell, I'm trying to it's very vague still, just by talking about it, there's so many layers, but in basic language, it's basically to enable an individual of all ages with underlying physical, mental, developmental, and emotional ailments through the use of therapeutic techniques to enhance independence and participation in what they perceive as meaningful and purposeful everyday life tasks. Okay, so Maslow hierarchy of needs. This is something that I really try to base my treatment approaches on, and I don't know if you're aware of this. This is, let me open this up because, so at the bottom of the pyramid, this is what makes up a person and how it makes them more, not healthy, but just what we should have. So the first part of this pyramid is we should have food, water, warmth, and rest. This is something that is our basic needs. Above that are our safety and security. Is this person or patient safe in their environment? Is this person having enough food and have enough rest in their environment? So this is all taking into consideration in the plan of care and intervention that is happening in occupational therapy visit every day. That's what you do. Belonging and love needs, like how is their intimate relationships? Is it affecting their health? How is their self-esteem? Is there an abusive relationship? Are they not able to interact with people or get out of the house as much? Like what's happening? And then the top is self-actualization. And this is where when everything is coming together and it's like they can meet their full potential. So we kind of want to try to fill up that top pyramid where we want to make sure that they get all their basic needs met and their physiological or psychological needs met. And then we can meet self-actualization, achieving full potential, including creative activities. So that's why this pyramid is so important, because I feel that in every treatment, you really should have that understanding to help enable a person to be participating in their everyday life. Now, settings, I said that we are everywhere. Look at how much settings we are in. And this is not all of them, but you have skilled nursing, mental health centers, schools, pediatric outpatient, orthopedic outpatient, inpatient acute care, intensive care, neonatal, home health care, which I'm in right now, which I love, prisons, which try to enable people who are in prisons to be able to integrate back into civilization after being in prison for a long time. I think that that's an incredible job. And then community centers. I don't want to digress too much, but it's just amazing. So I've already talked about what we do, but I'm just going to break it down into 5 things. So say I'm going into a home and I'm going to do an evaluation. I'm going to evaluate the patient's physical, mental condition, so vision, cognition, musculoskeletal, emotional well-being, their home environment, safety, and then I will formulate an individualized treatment plan to that environment and that person and what they need to create patient-centered specific goals. I already said assess patients' home and work environment. Also recommend durable medical equipment or maybe environmental mods, like they need a grab bar near their toilet. And then finally, with the treatments, which you see them so with home health care, I have to tell you this, you see a patient every once or twice a week, because that's the frequency that's typical of a home health occupational therapist. So in these visits, you will train the individual as well as the caregivers on how to use like a Hoyer lift or a slide board, which is something that helps people slide to and from the surface, help them with adaptive feeding equipment, train them on how to do safe transfers. And then what you do is, with the assessment, you document the progress and report it for billing purposes and reporting purposes. So that, in a nutshell, is what we do every day. Okay, let's see if I can scroll over here. So our primary focus is to get people, the patient, the person, independent, or to increase their participation in daily living activities. We call them ADLs. We always refer to them as ADLs because it would be a mouthful to have to always, write that in our notes. And then instrumental activities of daily living. And I like to say in the acronym IADLs. So I am going to go into depth on what activities of daily living are, and I'm going to refer to them as ADLs. So a basic daily life task is getting to and from a place. So getting up out of your chair, getting on and off the toilet. And then it's also mobility, getting in and around your house. And then there's grooming hygiene, which is you're going to be, shaving, brushing your teeth, dressing, bathing, toileting, eating, and then also continence if you're dealing with a catheter bag or in urinary incontinence. So we deal with that as well. And then the IADLs are instrumental. So they're basically outside basic needs. So shopping, community mobility, so getting to and from appointments, driving if they're able to drive, housekeeping, how are they going to vacuum, meal preparation, how are they going to prepare a meal? Are they able to manage their medications? And then are they able to manage their disease process? Do they know how to tell what symptoms are? And then are they able to access their telephone, And then leisure. What do they like doing? Do they like carving wood? Are they having a hard time with pain in their hands and they can't do, their woodworking like they always wanted to do? So we work on the individual's like primary focus. So what's important to them? And then what's essential. So those are.
So real quick, if we want to jump back to the last slide. So with the ADLs and the IADLs, can one or both of you kind of talk about how PT, also kind of assists with being able to meet these ADLs and IADLs, and just for me as a layperson, not really understanding PT or OT that well. How do the two work together to help a patient meet their ADLs and IADLs? Because it seems like, and correct me if I'm wrong, that physical therapy is more the strengthening, mobility side of things, where occupational therapy helps kind of like fine tune like those specific skills. So, Nadine or Lily, kind of jump in with, how the two kind of work together for these areas.
So I will.
You can speak to the physical therapy piece, Lily. Why don't you do that?
Okay. So physical therapy, we work alongside. We sometimes co-treat with physical therapy because we do functional mobility and functional transfer. So we have people walk to and from the bathroom. We have people getting on and off the toilet, and that's a functional transfer. And a lot of times PTs are really working and focusing on their mobility aspects and their lower body and how they can correct gait patterns and to improve their strength in their legs to be more mobile. Or like after a knee surgery, they're going to work on their range of motion to see how much they can get so that they can get up the stairs. So we work synonymously with PT because this is very important for the individual. We work more holistically because we work on what they call the occupations, the ADLs and the IADLs that will enable a person to be more whole and to be integrated into their environment. So I'll give you an example of PT-OT working together. So I love working with this one PT who we see another patient together, and we'll see them every week. And we're basically trying to enable this person to be independent with getting in and out of the shower, but also teaching the caregiver how to do it. And we want them to only have one person get them in and out of the shower. Right now, they are two. So they require a lot more assistance. So PT's working with the strength aspect and getting in and out and transfers. And I'm working with the dressing and bathing piece and the shower transfer and what medical equipment they're using. So we're both working on the same patient together, but have different goals. Does that make sense?
That does. And so in a situation where a patient may need both PT and OT, are there, for those that have never had home health services, do both come to the house at the same time? Are you guys scheduled on different days, different times? Kind of how would a schedule look in that respect?
So if the patient needs two professionals for a safety aspect, oftentimes OT and PT will work together, like I said, with that shower transfer. We typically like to spread out OT and PT so that they can benefit from having us at different times so that they can get stronger. But if it's safety and also we have one goal, we're going to work together. So I think that answered your question.
Yep, that's perfect.
Yeah, all right. That definitely, Lily. And, in terms of physical therapy, there are also physical therapy aides. And in some agencies, we have occupational therapy aides too, who will do a majority of the visits. And oftentimes a physical therapist and occupational therapist will be doing the admissions, the starts of care, reassessments, evals. and the PTAs or OTAs are doing a minority of the exercises with the patient or fine-tuning some of those ADLs if you are an OTA working in an agency. So there are quite a few people that go into a patient's home depending on what their diagnosis is at the time of start of care. And as you can see, everybody has their little slot that they're in, working together holistically for the patient to get them back to their baseline as soon as we're able to for that patient. And every patient has something a little different. And occupational therapy is another slice of the pie where we're working to get the patient back to their baseline. And it's hugely beneficial for some of these patients, especially stroke patients.
Perfect. All right. Yeah, I think that at least helps me understand it a lot better. So I hope that will help for everybody else too. So so Lily, continue on.
Okay. So now we're going to, I would like to do examples of what type of treatments go with each ADL. So, and I'm going to kind of go into kind of the nitty gritty on like just how and why we choose what we choose with certain ADLs. So bathing, for instance, there is, say a person is non-weight bearing, unable to put any weight on their right leg because they broke their femur and it was a shatter and they can't, it's not just a simple fix. So they'll need to be able to take a shower when they're cleared by their doctor, and they can't get in and out of their shower because they have a tub shower, which you'll have to navigate going over the tub to get into the tub, which would cause you to weight bear. So what you do is you implement a tub shower or suggest one, and then you show them how to use it. And then it also prevents falls and prevents them from putting any weight on their leg. And then you train the caregiver and the patient or both on how to use it. Dressing. Okay, so we use a variety of different techniques. I mean, there's so many things to dressing that you don't even think about. But here's an example, a total hip precaution with a posterior approach, that's what they call it. They give, or the surgeon gives 3 months where you cannot bend your hips past 90 degrees. You can't cross your legs or twist the leg that was being repaired. So can you imagine trying to get dressed with all of these precautions? You can't even reach your feet. So we have long-handled equipment and different adaptive equipments and strategies that help enable that person to be independent. Say they live alone and need to be able to dress on their own so that they can actually get to their doctor's appointment. So that's a really important thing. That's why occupational therapy is so important. I can go over grooming. So say there's a person that has struggling with dementia and they're actually on a lot of blood, they're on blood thinners. So how do we enable them to be independent without being at risk for injury? Electric razor, let's think about that. Self-feeding, oh my goodness, this person has an intention tremor and it's so significant that they can't even get their food to their mouth when they're eating. Well, we have weighted utensils that are built up. And then, like, say for a functional transfer, say someone has a leg amputation and they want to get to their wheelchair and back. We do slide board transfers, caregiver and patient ed. And then functional mobility. I know physical therapy works with ambulation. Hey, what about how do you manage your long O2 cord? That is an occupation that people are going to have to do, especially if they're going to be dealing with a long O2 cord for a long time because they have a chronic condition that's impairing their cardiopulmonary system. So that's another thing that's different than PT too. So you're kind of like working on nuances, just different things that we're looking at. So typical durable medical equipment, we have the tub shower bench. This is what I'm talking about when I talk about a tub shower bench. Here's the tub shower. So you get to this bench here, and then you sit down, and then you lift your legs over the tub. So you're not actually standing when you're on this bench. This is a raised toilet seat. If you want to maintain your hip precautions, you better have a raised toilet seat, because if you are too low, you are going against your hip precautions. And then here are the weighted utensils that I was talking about with the built-up grip.
So Lily, completely random question. So for the tub shower bench, are there any sort of, systems or anything in place that can be used as far as like a shower curtain going over it that may actually prevent water from landing on the floor? I know other people that they run into this issue with the shower bench and how you essentially can't shut the shower curtain anymore, and then water gets on the floor, and then we've got the issue of cleaning up the water on the floor. Just any sort of recommendations that you may have related to that?
Oh, definitely. This is something that happens more frequently than not. That's a great question, actually. So water, it will go down to where the lower aspect of it. So if you don't, so basically you have to get a shower curtain that is tucked into the patient and is going into the tub, or else the water is going to spill on top of the tub bench and go outside of the tub. But people don't think about this because they're just trying to take a shower. So that is also a fall prevention technique that we also have to instruct too with the tub shower bench. So it's all about tucking in the curtain underneath your bottom and making sure that the edges of the curtain is going into the tub, flowing into the tub.
Perfect. That's awesome. I'm gonna remember that one for sure. So
Lily brings up a really good point just about safety in general. That is definitely the highlight of everybody's day. First thing in the morning when you're looking at your patient caseload, safety is always a priority. And this is something that Lily really stands out amongst her peers from my perspective, is that she really puts that at the forefront for the patient. And Lily's been in situations where her patient may not be presenting very well, and she's really good about advocating and getting that patient to the space that they need to be, whether it's the ER or, talking to the primary care provider. I just wanted to bring that to the forefront, that everybody has a role in that, and Lily is exceptionally great at advocating for her patients.
Awesome.
Thank you so much, Nadine. I sometimes don't take compliments well, so thank you so much.
You should.
So here is a slide for other durable medical equipment that I may have been talking about that probably went over your head. I hope it didn't, but they're really important, especially in the home health care field. Commodes. Okay, bedside commodes are essential, especially if you have frequency of urination at night. Eliminating the need to go to and from the bathroom, especially if your bathroom's too far. Having a place right next to your bed is safer, although it's not safest, because having a commode and doing a transfer at night isn't very indicated too, but it simplifies the task and reduces the risk of a fall. So there's the commode, there's the Hoyer lift, which is a total dependent thing. It's a heavy lift that lifts people with a sling. I don't know if you can see this. Do you see my cursor? Is that? No, probably not. Well, anyway, you can see? Okay. Well, this is where the sling would, oh, you can't. Well, there's a sling that attaches to the Hoyer lift mechanism, and it allows the person to be, there's a hydraulic system that lifts the patient up so that it can go, so that the person can go either into their chair or into their bed safely without using their physical body. Although this is a total dependent activity, there's a lot of people that need to be trained in how to use it, and that's where my profession comes in, to make sure that I know how they're positioning the patient in the sling safely, if their arm has restrictions, and then just hoping that they're moving the patient safely in their bed so that they're not going against their orthopedic conditions, such as going, their arm is non-weight bearing, so they're not rolling to that side, or they have sternal precautions. There's a lot of things that go into it. Okay, and then the detachable shower head is my favorite thing because it enables people to access their shower head to get to the back of their heads and while they're sitting down, and it just is a game changer for people who are sitting while they're showering, so they can actually have more ability to access areas that wouldn't necessarily be able to access. And then finally, the bidet is amazing. Okay, say someone can actually reach the back of themselves. This will make someone independent in their hygiene. So say they have a shoulder replacement or they have no mobility in their upper body. They can be more independent with having this feature. So, okay, here's the adaptive equipment I was talking about earlier. There's the long-handled reacher at the top. This will help you with your hip precautions so that you're not bending forward past 90 degrees, so you can get your pants on or you can take your socks off. There's the long-handled sponge with the blue sponge head. That can help you access the back of your body and the feet of your body, like your bottom. And then in the middle is a dressing stick, and that will help you get your shirt over your head or take your socks off. There's a lot of things you can do with the dressing stick. The sock aid is if you can't bend forward to get your feet, you can use the sock aid to help you put your socks on. So that's the equipment that we use a lot often. Okay, and then environmental modification. We use these a lot in the home health care with physical therapy and occupational therapy, and even speech therapy. Environmental modifications are important for people to become more independent and in their environment. So as you can see above, there's the stair glide. That will enable someone who cannot use the stairs to get up and down to their bedroom. Really important. As you can see on the side of the picture of the stair glide, there is a picture of a stair. Now, some people with visual impairments will not be able to see the stair and where it ends and where it begins. And so altering the color or putting tape at the edge of the would help them see the stairs, so it's safer for them to get up and down the stairs. So that's a good thing. Ramps. So you see that threshold ramp down low on that picture? So say you use a walker all the time and you want to get and navigate on that threshold, you can get through it safer and easier with that ramp. It's not as much of a trip hazard. And then if you see on the right side of that picture, this is an amazing device that's actually relatively cheap, and you can get it on Amazon like for $8, and it is a game changer. So people who are unable to get to their lights or turn them on and off, you can, with the click of a button, turn it off, and it will be connected to their light system. So if you're non-ambulatory or you're unsafe at night, this is a game changer for a lot of people. So recommending these types of products is essential in our job. So, and knowing about them and researching different items that may help, technology that may help them. That's just such a important thing. So IADLs, therapeutic treatments. So IADLs, I'm going to try to have you remember what they are. They're instrumental activities of daily living, including med management, shopping, and all that. So meal preparation. If you're able to ambulate now, how are you going to prepare your meals now that your arm is still in a sling and you can't put any weight on it? What are you going to do? Well, hey, look at on the right side here, there's a rolling walker tray, and you can put all of your items on that tray. I mean, I guess if you had an upper body sling on, you wouldn't be using a walker, but okay, so you're very unbalanced and you need both hands on the walker. you have this tray, you can bring your food into the living room without any problem. So that's a great adaptation for this person who lives alone that can actually transport their food to their wherever they want. And then like safety, emergency preparedness, people that are living at home and they have a cognitive impairment and they don't have a life alert. Look below, there's a wristwatch that you could wear, and that can activate a lifeline to the 911, and they can call and be in contact with them immediately. So making these recommendations are pivotal to create a safe environment for them at home. And then also just offering social services such as Meals on Wheels if they can't do meals, if they can't make their own meals and they're at risk for nutritional, not having enough nutrition or food in their house. So there's so much more to it, but those are just examples. Okay. Another example for an IADL treatment is the phone. People want to be able to communicate with their loved ones. So say if someone has ALS and they do not have the ability to use their upper body because they have significant decline in their upper body and they have spasticity, which causes like a flexor synergy tone, but so they can't open their hands to accommodate whatever the phone. Oh my goodness, what are we going to do? So I'm like, let me strategize. We have different techniques. So there is a tilt switch, which will allow the person to use the tilt of their head to navigate their phone, and it will be integrated into their phone, iPhone especially. There are things called the eye gaze. It's the Tobii eye gaze, where they use their eye to navigate their computer or their iPhone to be able to get to communicating with their family, emailing, Facebook, all that. And then you have to train them in these adaptive strategies, or I think they call it assistive technology, which is a game changer for people who do not have mobility in their upper body. And then there's also like the mouth stylus. If they can use, this is kind of old school where, assistive technology wasn't around or was less prevalent or developed. And the mouth stylus is basically using the mouth, and there's a stylus that comes out of your mouth, and then you have a bracket where you put your iPad, and then you use the stylus to navigate through your iPad. So that's also another thing. Another important thing for IADL treatment is health literacy. So say you have someone with chronic obstructive pulmonary disease, you want to teach them how to do energy conservation techniques, how to breathe correctly, or, how to pursed-lip breathe. You want to be able to have them manage their symptoms and know when there are red flags so that they can contact their doctor or go to the emergency for safety. And then, so there you go. I'm going to just skip through this slide because I think I'm going a little too long. So here's I have to tell you, this is the wrong slideshow, but I'm going with it. It's fine. I wanted it to come up flowing, but it's the wrong one. So, okay, it's all right. I'm working with it. So this is the tilt switch, I already talked about that. The wheelchair. So a wheelchair can be customized so that the patient can really reposition themselves for skin integrity purposes, so to prevent their from decubitus ulcers, which are like bed sores. So assistive technology, I would say wheelchairs are an assistive technology because it allows the person to be able to do that independently and to navigate through their environment. There's also the OB feeding system. So if you don't have mobility in your upper body, you can actually feed yourself with this machine, which is in the center. On the top of the machine picture, there is also the Tobii eye gaze, and that is the Tobii system that's on a bracket, and there's someone that's in a wheelchair using their eye gaze to navigate and be able to talk using their eyes, using quick phrases. I've worked with this before, and be able to manage their computer system with the eye gaze. And then On the bottom to the left is an orientation clock. So say you have dementia and you're having difficulty knowing what time of day it is, what day it is, and is it morning or night, or like what year is it? It's right there, and that will help them orient to time of day, year and everything. So these are all really important.
So Lily, it seems to me that equipment for ADLs and equipment for IADLs are different in the respect that the IADLs are more, technology-based equipment versus the equipment that is used more for ADLs is more just physical pieces of equipment that an individual would use.
No, that's different. No, ADLs and IADLs will both need assistive technology. So you see below the OB self-feeding system, that is an ADL, a basic need to feed yourself. Okay. And then the wheelchair, to even be able to reposition yourself, is also a basic activity of daily living. Okay. And then you have the higher level, which is instrumental, and that is being able to communicate with your family and then access your email and stuff. So no, it doesn't matter if it's an ADL or an IADL. Assistive technology just helps people be more independent in their situation or increase participation. Yeah. Sorry, I didn't mean to. I want to make sure that you understand that. So
yeah, no, that's perfect.
Yeah.
Okay, let's see here. Is this my last slide? No. Oh, I should have said why I love OT at the beginning. Okay, so I love OT because it empowers me to think creatively, and I am an artist. It helps me be autonomous, so I am self-driven. I'm able to do what I want to do with my individual patients, but they are the driver, obviously. I can work in a variety of settings, to be able to see and explore other settings is a great, I think that's a great, my career is a great opportunity to do that. And it's holistic. It's a hands-on approach. You have to be athletic to be in this field because you're like running, moving, and shaking. It's scientific and evidence-based, so I love that. And I help others achieve their goals. And I'm able to explore areas of my profession that I'm passionate about, like assistive technology, and that's why I was so excited about talking about it.
Perfect.
So I think that's it. Yeah. Does anybody have any questions?
I'm not in our comments box. I'm not seeing any questions currently, and I know I've asked all the questions that I had, related to this presentation. I think, from the perspective, for you, Lily, in particular, again, clearly a passion for OT, and really, I know you and I had talked, previous to this presentation itself, and just kind of the fact that OT and art are very similar in the respect that, as you're trying to determine what you're going to be painting next, or, how the treatment you're going to be providing to an individual, it's a blank canvas every single time that you're starting with somebody, and you have the ability to, determine what is going to be in the best interest of that particular patient, that particular painting, and what you originally thought may be the course of treatment for that individual can change and fluctuate based on their needs and what and what they need to work on in that respect. And I think that it seems to me that there's a lot of similarities between OT and art. And, it seemed like it was a pretty natural transition for you to go from one world to the next.
Agreed. And I'm still in the art world. I still do it. But yeah, definitely. You definitely have to be a creative person to be an OT.
Perfect. So, Nadine, is there anything else that you want to add just from the perspective of, continuity of care between OT, PT, skilled nursing, just kind of how it all works together?
Yeah, as I expressed earlier, everybody has a little slice of the pie in terms of helping the patient. There's excellent communication between PT, OT, nursing throughout the day with each other, even though, we are working in remote settings and clinicians are over mountains and rivers and, they're all over the place. We still have the capacity through technology to be able to share what that patient needs throughout the day. And that is really important for the patient and for the clinicians. And they're so great at advocating for the patient every single day. And, PT works with, more of the broadest perspective of the patient in terms of, movement. OT's working with the patient in a different perspective. Yes, it's about movement, but it's about how they use that movement and what tools they need to navigate with, and how, like, even a stroke patient is able to, pick up a tool and eat that whilst they're starting to get a little better. And then you have the nursing perspective, which is a little bit of both. Everything works together. Everybody's helping each other out for the patient. Nursing is probably more focused on, we're always focused on ADLs. Every single discipline focuses on ADLs, whereas nursing is looking more like the medication piece of that. If a patient has wound care, however, that wound may be something that's impacting the way that they're walking, or they're a post, total knee patient. So, PT's working with the patient to getting them up and moving. If they have another wound, then nursing's looking at that too. And then OT's working with the patient to see, oh, hey, can I actually, get onto the toilet and move the way I'm supposed to? So everybody works together, and I feel exceptionally fortunate to oversee this great team of clinicians in an interdisciplinary setting, and very fortunate.
That's awesome. Lily, any final words about OT?
I think I covered everything, but there's so much to cover. So
You did amazing.
No, I want to thank both of you for taking the time to talk about a significant part of the services that VNH provides to the community in both Vermont and New Hampshire. And I want to thank everybody who was watching this live, or anybody who's watching this later. And just so everyone is aware, our next presentation will be happening May 18th, and it's going to be around spiritual and mental health related to hospice care for both the patient and the family and friends around that patient. So I hope to see a bunch of you at the next presentation. And again, Lily and Nadine, thank you so much for being a part of the presentation today.
You're welcome.
All right. Thank you.